From the JAMA Network, this is JAMA Oncology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Oncology.
Hello and welcome to our listeners around the world. You are listening to JAMA Oncology Author Interviews. Thanks for joining us. I'm your host, Vivek Subbiah, medical oncologist and chief of early phase drug development at the Sarah Cannon Research Institute, Nashville, Tennessee. I'm also the web editor for JAMA Oncology and the podcast host for today. We're going to explore a topic that could revolutionize the way we approach cancer treatment, specifically the management of chemotherapy-induced kidney injury. Our guest is Dr. Shruti Gupta, a researcher and author of a pivotal study that sheds light on the prophylactic use of IV magnesium to significantly reduce the incidence of cisplatin-induced acute kidney injury, or also be known as CPAKI. This study spans an impressive data collection period from 2006 to 2022 across 5 major cancer centers, offering insights that could reshape our clinical practices. Join us today as we dive into the challenges and potential future impacts of this research. Whether you're a healthcare professional, a patient, or just someone fascinated by medical advancements, this episode is packed with valuable information that you won't want to miss. So without further ado, let's welcome our esteemed guest and get started on this fascinating journey into the intersection of the world of oncology and nephrology. Dr. Shruti Gupta from Brigham and Women's Hospital, can you please introduce yourself?
Thank you very much for having me. I am head of our onconephrology program, so I'm a nephrologist by training. I'm at Brigham and Women's Hospital and also with a dual appointment at Dana-Farber Cancer Institute.
Fantastic. Thank you so much for being here today.
Thank you for having me.
So your study highlights a significant reduction in cisplatin-induced acute kidney injury with the prophylactic use of IV magnesium. Could you share with our broad listeners of JAMA Oncology what initially sparked your interest in exploring this particular intervention and how it evolved into such a comprehensive multi-center cohort study?
Yeah, so cisplatin is a drug that has been around for a long time, over 50 years, and it remains the cornerstone of treatment of a number of different cancers globally as well. Yet we know that cisplatin is associated with kidney damage. Despite this, we actually don't have data from randomized clinical trials testing whether treatments actually improve outcomes on a large scale. And there's good biologic plausibility for why a drug like magnesium may actually improve outcomes and potentially allow for cisplatin-AKI prevention. There's some data from some animal studies as well as some in vitro studies suggesting that magnesium leads to upregulation of these transporters in the kidney proximal tubules and allows for cisplatin excretion in the urine. And this has not been tested on a larger scale in humans. And so when we don't have data from randomized clinical trials to guide us, you can actually use observational data to quote unquote answer the question about whether a drug improves outcomes.
The study spans data collected from 2006 to 2022 across 5 major cancer centers. What do you think are some of the unique challenges you faced in maintaining data consistency and the accuracy over such a long period of time and across such diverse institutions and locations?
Yeah, so this study was truly a labor of love and a Herculean effort in that we started data collection back in 2018, and it really took us 4 to 5 years to really curate this very rich data set. And there are challenges as each hospital has its own electronic medical record system, its own methods of extracting data. And then once you get that data, you have to unify it across all of the sites, clean it. And so it really was a massive, massive effort. But I think it allows us to feel fairly confident in the data, having put in, all those years to generate this very well curated data set.
The study discusses both preclinical and observational findings related to magnesium's role in attenuating cisplatin-induced acute kidney injury. Can you elaborate to our listeners on how these preclinical insights translated into your human cohort study design?
So we know that magnesium wasting is very common in patients who are receiving cisplatin. Up to 50% of patients will develop some degree of hypomagnesemia at some point following cisplatin administration. There are these studies from animal models that suggest that hypomagnesemia leads to downregulation of these transporters, thereby preventing cisplatin excretion in the urine. And then there are subsequently models showing that giving magnesium leads to upregulation of these transporters to allow cisplatin to be excreted. And there are data from smaller studies in humans as well suggesting that there may be a benefit to magnesium, whether that's PO or IV supplementation. But this really has not been tested rigorously on a large scale or in the setting of a large randomized clinical trial.
Your findings suggest that even patients with normal baseline magnesium levels might benefit from IV magnesium. How do you think this could change the current clinical guidelines or protocols from administering cisplatin?
Yes, it's a great question. And I do think that there is a lot of variability already in terms of some sites give a lot of magnesium and then some sites don't give any. That's actually this interhospital variation that we were able to therefore leverage to test whether this intervention works or not. I'm a big believer in magnesium, and this data really sort of adds credence to this finding that magnesium may actually be beneficial. I do think that perhaps this means that magnesium, which is cheap, effective, readily available, may be something that we could be giving prophylactically to patients who are receiving IV magnesium, even in the outpatient setting. Although there's still some unanswered questions like what's the exact dose that patients should be given. That's not a question that we were quite able to answer with this study. I actually do have a randomized clinical trial underway where we are testing whether magnesium improves outcomes in patients who are receiving hyperthermic intraoperative chemotherapy with cisplatin. So hopefully that will also shed some light on the efficacy of magnesium.
In the paper, you mentioned that the results warrant randomized controlled clinical trials in the future. What do you envision as the next steps in this research, and how do you think they could impact clinical practices for patients with cancer today in clinic undergoing cisplatin chemotherapy?
Yeah, so our study focused only on patients receiving their first dose of IV cisplatin. So we have to remember that that's sort of one of the caveats. And I think it still is very impactful in the sense that we know that if even IV magnesium after a single dose of IV cisplatin may be beneficial, then one could potentially even extrapolate that it could be beneficial for successive doses as well. But again, we don't have a lot of data in terms of the amount or the timing of magnesium supplementation or repletion. Is there a different amount that should be given based on the underlying magnesium level or the pre-existing magnesium before they actually start the cisplatin treatment? And I think we do need data from a randomized clinical trial to test this. One of the challenges, though, with doing that is if you want to give a high amount of magnesium, that can be challenging in an outpatient setting, as we know that magnesium takes time to infuse as well. So, this is one of the beauties of being able to use observational data when you don't have the ability to carry out a randomized clinical trial. But I do think that we do need to do this, and there are potential ways we could do this, like perhaps a subcutaneous pump of magnesium rather than IV magnesium. So hopefully there will be some further studies down the line to support our findings.
Is there any harm of giving magnesium to patients with cancer?
So, magnesium is a drug that's readily available. We give it all the time to our hospitalized patients, our outpatients, and it's very safe. And we're in the midst of conducting a randomized clinical trial testing where really high doses, whether that actually improves outcomes and prevents cisplatin-associated kidney injury. As part of our trial, we're giving up to 30 grams over 24 hours to patients. And we did several pilot studies testing even higher doses of magnesium than that. And overall, we found that it was very safe. There is, of course, a risk of slowing of the heart rate, bradycardia, arrhythmias with very, very high doses of IV magnesium. But even in the doses that we are currently giving in our trial, we're finding that it's overall safe. And just to put it into context, pregnant women with preeclampsia get massive doses of magnesium and tend to tolerate it very well.
Thank you so much. Important to keep that in the context, for our patients with cancer. So, in terms of patient care, what are some potential implications of your study for oncologists and nephrologists in developing personalized treatment plan for their patients in clinic today? How do you foresee this affecting patient outcomes?
With this really rich data set, before we even embarked on this study, we actually developed a risk prediction model for cisplatin AKI, where we derived and then externally validated a risk prediction model for cisplatin AKI. And so what I envision is that we could first use a risk prediction model like that to assess any individual patient's risk of developing kidney injury after cisplatin. And in those patients that are deemed high risk or very high risk, those patients may benefit prophylactically from receipt of IV magnesium prior to getting cisplatin. And so I do think we can utilize all of these studies and this data that we have to essentially risk stratify and therefore then give magnesium to those patients who are at highest risk.
Is there any final thoughts for our audience?
I think that the main thought is that as we think about potential treatments for cisplatin-associated kidney injury, it's important to always come back to biologic plausibility and which treatments do we actually have some foundational knowledge. And we do have data from animal models supporting the role of magnesium. And so I think it's important to essentially take these findings from the bench to the bedside and then apply them to observational studies, large randomized clinical trials to test whether medications that are widely available, like magnesium, are effective. And I think that's really important, particularly since cisplatin is used globally and because magnesium is cheap and widely available. I think it's something that could be utilized well beyond just the United States.
Thank you so much, and enlightening us about the fascinating intersection of oncology and nephrology.
Thank you.
I am Dr. Vivek Subbiah, and I've been speaking with Dr. Shruti Gupta from the Brigham and Women's Hospital on her latest publication, Intravenous Magnesium and Cisplatin-Associated Kidney Injury, a multi-center cohort study. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.